Chapter 53, Concepts of Care for Clients with Liver Problems. The priority concept for this chapter is cellular regulation and immunity. The interrelated concepts for this chapter are comfort, fluid and electrolyte balance, and nutrition. Cirrhosis is characterized by widespread fibrotic bands of connected tissue. This can be caused by diseases or toxins. As cirrhosis progresses, the liver becomes nodular, and these nodules can block bile ducts and interfere with the normal blood flow as well as lymph flow. Early in the disease process, the liver will be enlarged and firm. As cirrhosis progresses, atrophy will occur and liver function will be impaired. This can take months or even years. Compensation can occur. If there is compensation, the liver is going to be scarred and cellular regulation is impaired, but the liver will still carry out all of its normal functions without any outward signs and symptoms. For decompensated, the liver function is impaired and signs and symptoms are apparent. Cirrhosis can lead to many complications, including portal hypertension. Portal hypertension is a persistent increase of pressure in the portal vein. This causes a backflow of blood and results in splenomegaly, ascites, and esophageal varices. These varices are very similar to what you see in the legs when somebody has varicosities in the legs, and they're abnormally dilated veins. The difference is going to be that they occur in the esophagus. They're very friable, which means that they're prone to bleeding, and any type of injury can cause profuse hemorrhage. The varicosities can also rupture due to increased abdominal pressure. So think about your clients that are vomiting, coughing, obese, heavy lifting, vigorous exercise. Those can all lead to rupture. This is considered a life-threatening emergency and should be addressed immediately. Individuals with cirrhosis can also suffer from coagulation defects, and this is as a result of impaired formation of clotting factors, the prothrombin, by the liver. So when you're drawing coag studies on these patients and you're checking their PT, they're going to have an increase in their PT or their prothrombin time. If they have splenomegaly, they're also going to have a destruction of platelets, which is going to increase their chances of bleeding. These clients could have some jaundice or yellowing of the skin. You also make sure that you're assessing the eyes, the sclera of the eyes, especially with individuals with darker skin tone. And this jaundice occurs because of the liver's inability to excrete bilirubin. Clients could also be complaining of itching or pruritus, and that is going to be caused by the high levels of bilirubin. PSE, or portal systemic encephalopathy. So these patients will be altered, their cognition will be altered, and they could also have some mood disturbances and mental status changes. Speech can be affected with these clients, and they can also end up with a tremor. This is caused mainly by a buildup of ammonia, which is a byproduct of protein breakdown. This occurs in the gut, and then it's excreted by the liver. There are many factors that can lead to PSE, including diet. So if their diet is high in protein, infection, constipation, opioids, sedatives, hypnotics, and diuretics. Hepatorenal syndrome, that is going to be a sudden decrease in urinary flow. These clients will also demonstrate an elevated BUN, creatinine, and increased urine osmolality. And then lastly, a spontaneous bacterial peritonitis, which we discussed peritonitis in one of the previous recordings. For hepatitis, there are a lot of different varieties of hepatitis out there. There's autoimmune, hepatitis A, B, C, D, E, and then there's neonatal hepatitis. And then the other thing is there's NASH. Something similar to this is NAFLD, and that's going to be the buildup of extra fat in your liver cells. And it's not caused by alcohol, it's caused by your diet. And this stands for non-alcoholic fatty liver disease. With the other types, it's very important to differentiate how those are transmitted. I always remember if it ends in a vowel, it starts in the bowel, because that kind of helps me remember the different types and how it's spread. Hepatitis C, that is going to be the second leading cause in the United States. And then B and D are going to be the most common worldwide. We already covered the NAFLD, the non-alcoholic fatty liver disease. And then lastly, this one is going to be caused by alcohol use. These clients can have abdominal swelling. We refer to that as ascites. Enlarged blood vessels just beneath the skin surface. You can see this most notably on the abdomen. They will have an enlarged spleen, red palms, and of course jaundice again. So 1 in 10 Americans will have liver disease, and about 7,000 Canadians will die annually from liver disorder. It's pretty significant. For assessment, we want to make sure that we're obtaining an accurate and thorough history. Ask your clients about their exposure to chemicals, ask about their alcohol and drug use, and don't forget about herbals. A lot of times we overlook those as healthcare professionals, and they do cause quite a bit of interactions within the body. Determine if they've ever been stuck with a needle, like a dirty needle, if they're sharing needles, if they're an IV drug user. Tattoos. Tattoos, not so much if they have a tattoo in America anymore, because we're pretty clean and they're regulated. But if you think about it, some people do travel overseas and they may get a tattoo in another country where healthcare practices may not be as stringent. Imprisonment, that places them at a higher risk for contracting hepatitis. And then, of course, employment. Healthcare workers were very high risk for contracting hepatitis because of the risk for needle sticks and exposure. So make sure that you're keeping yourself safe. Don't recap needles. Make sure that you're using the safety device, the safety lock after you're done using the injection. Place them in a sharp spin right away. Just a lot of things with there. Same thing with firefighters and police officers for the same reason. You're going to assess for their sexual history, inquire about family history, especially if they have somebody else in their family that has hepatitis. They're at high risk for contracting that, and any previous medical history as well. And these are all the assessment findings that we've discussed previously in this PowerPoint recording. So make sure that you download this PowerPoint and reference this. Here's an illustration for esophageal varices. So remember, you're not going to be able to see these varicosities because they're inside the esophagus, but they look very similar to the tortuous blood vessels that we might see on a person's leg if they have varicosities, but this time it's internal and located in the esophagus, so right here. And these clients are at high risk for hemorrhage if they rupture. For laboratory assessment, we can see some of these things on a CMP, but a better test to collect would be an LFT or a liver function test, and that's going to go through all of these diagnostics here. For the first three items on here, the AST, ALT, LDH, alkaline phosphatase, and the GGT, those are generally going to be elevated. The serum protein and the albumin are generally going to be decreased. We could also be performing some imaging like an abdominal x-ray, a KUB, CT, MRI. These are going to be more common than the elastography. Even more common for liver assessment is going to be a liver ultrasound. Arteriography, EGD, or an ERCP could also be performed. These clients can be suffering from third spacing, so we want to be cautious with fluid overload. Hemorrhage, we talked about that with esophageal varices, so keep that in mind because they do end up with a lot of portal hypertension, and that can place them at high risk for this. And then hepatic encephalopathy, and that can be due to shunting of portal venous blood, but typically I see it as a result of serum ammonia levels. So we're going to manage their fluid volume, do strict INOs, daily weights, a lot of the things that we covered with fluid volume overload with the fluid and electrolyte section we would be doing here. Prevention and management of hemorrhage, which there's another slide on that, and then preventing or managing hepatic encephalopathy. So keep in mind all of your safety precautions here because a lot of times these clients are altered. So here is a tube that is placed. You can see the tube placed down through the mouth and into the esophagus, and a balloon is inflated in the area where the varices have occurred. And to be clear, this is for the management of hemorrhage. So they would only place this if there's going to be an imminent hemorrhage or hemorrhage is present. And there's a couple different openings that you see here. This is going to be the esophageal balloon. So you can see down here, here's the balloon. So that's where the inflation is going to occur. This right here is going to be for suction. So that port right there. And this one down here is going to be to inflate the gastric balloon. The esophageal balloon right here, that is typically inflated to a pressure of between 20 and 40. And this is monitored by an attachment or a gauge. So you can see how this would apply pressure to any areas that have been ruptured. And then the gastric balloon has about 250 cc's of air in it, and this applies pressure to the fundal veins when slight traction is applied. Home management for these clients, they're going to need some PT and OT, nutritional therapy, so they're going to need assistance from a dietitian, medication adherence. A lot of the medications that we use, for example, like lactulose, it has a lot of unpleasant side effects. It's important to take to lower your ammonia levels, but it causes a lot of diarrhea. So a lot of times clients are non-compliant. So we want to make sure that they're compliant with their medication. We want them to sleep in an upright position, avoid alcohol. That can be really challenging for them. So they may need a support group for that or Alcoholics Anonymous. Nutrition, small frequent meals, low protein diet. We talked about bleeding, so we want to tell them how to monitor for signs and symptoms of bleeding, and then spiritual and psychological support as well. So our goal is to decrease or reduce or have no ascites. We want their electrolytes to fall back within normal limits. Of course, no hemorrhage is ideal or immediately managed if hemorrhage occurs. A reduction in encephalopathy or no encephalopathy. And then the highest quality of life possible. And then lastly, we want these clients to successfully abstain from alcohol and drugs if the disease was caused by these particular substances. For viral hepatitis, this is something that is reported to the health department, and it's mandated that we report that. And hepatitis itself is a term used for widespread inflammation of the liver. This can be acute or chronic, and viral hepatitis is going to be the most common. For hepatitis A, these clients typically have flu-like symptoms, so the symptoms can often go unrecognized because of that. They might confuse them with something else. It is transmitted through fecal transmission. Remember, we had said if it ends in a vowel, it starts in the bowel. So fecal to oral transmission is what we're looking at from contaminated food, especially shellfish, and then contaminated water. With hepatitis B, these clients typically are going to have fever, anorexia, nausea, vomiting, right upper quadrant pain, dark urine, light stools, and this is a bloodborne transmission. So we're looking at unprotected sex, also sharing razors, toothbrushes, and needles. And if you look at toothbrushes as being a cause, this is why sometimes families can contract this from each other, because a lot of times we keep our toothbrushes close to each other in the bathroom. Also, direct contact with blood of an infected person through an open sore or a cut, mother to baby during birth. But the good news with hepatitis B is most people generally recover on their own. Hepatitis C, that is bloodborne, and this is generally from sexual transmission or needle sharing. Most of these individuals do not recover on their own, and chronic infection is going to be a risk for them. Hepatitis C does damage to the liver over the course of several years, and this can lead to cirrhosis as well as liver cancer. Hepatitis D, usually transmitted by parenteral routes or sexual contact. And then hepatitis E, that's going to be waterborne infection. And again, it's fecal to oral, so if it ends in a vowel, it starts in the bowel. So that's how it's transmitted. That's more common in third world countries, and it's self-limiting and generally resolves on its own. A and B are declining now due to vaccination, and C is going to be the most common, and there's no vaccine for that. For A, recommendations are proper hand washing, especially after handling shellfish, and then avoiding contaminated food and water. So for assessment, we're going to perform a full health history. So ask about their exposure to hepatitis, ask about chemical exposures, drug and alcohol use, herbal use, inquire about travel, sexual activities, needle stick exposure, IV drug use, and military service, and then assess for a family history of liver disease. Physical assessment, you're going to perform a full abdominal assessment while asking about abdominal pain. Changes in skin color or sclera, you're going to be looking for jaundice. You're going to check for joint pain and myalgias, diarrhea and constipation, and really ask them in-depth questions about their urine and their stool. Ask them about consistency of the stool and the color of it. And the same thing for the urine. They could have fever and lethargy, malaise, nausea, vomiting, and the pruritus. Laboratory tests, we already covered liver enzymes, so we're going to be checking those again. And then blood tests specific to hepatitis. They could also perform a liver biopsy as well. These clients could have weight loss due to complications. So a lot of times you're going to see they're going to have a rounded, protuberant belly, and then they will still have like thin extremities, so they will have weight loss. Fatigue due to decreased metabolic energy, and then potential for infection. For nutrition, supply a diet high in carbs with moderate fat and protein, and the protein can be added or increased after their nausea subsides. Rest, we want to give them some static exercises, proper hand washing, monitor for fever, and then sanitary disposal of infected materials, not just while we're in the hospital, but teach them how to do that once they go home. For evaluation, we want them to maintain their nutritional status, so we can reassess that by drawing their labs again, checking their protein levels, checking their weight, monitoring their INO, assess them for their energy levels. So that's going to be questions that we ask them. Are they resting well? And then remain infection free. Okay, so we talked about non-alcoholic fatty liver disease, but there's also NASH, and NASH stands for non-alcoholic steatohepatitis. And what that is an accumulation of fats in and around the hepatocytes. There's no exact cause of NASH, but it may be linked to diabetes, obesity, high lipids, or even genetics. Testing and diagnostics are going to be similar to what we already discussed. We're going to be checking their liver enzymes, MRI, ultrasound, and nuclear medicine. Interventions are going to include weight loss, glucose control, and lipid lowering agents. The liver is one of the most commonly injured organs during abdominal trauma. For this, we're going to observe for hypovolemic shock. So we're going to be monitoring your client's vitals and their cardiovascular system. If this does occur and they do suffer from liver trauma, they may require ICU placement, surgery, and blood. Now keep in mind, not all clients will accept blood, so we may need to use some volume expanders instead. So for cancer of the liver versus metastasis, when we were in the oncology section, we had mentioned that metastasized tumors are very similar to the tumor of origin. So they would need to biopsy the liver in order to determine if it's a primary tumor versus a metastasis site. These are one of the most fatal types of cancer, and cirrhosis is going to increase the risk. These clients may be asymptomatic early in the disease process, and anytime you're talking about cancer and you have diseases that are asymptomatic in the beginning, that's why we see such a high fatality rate with them. So if we don't catch them till later in the process, they could be at a higher stage. Later stages, those clients are going to have some weight loss, anorexia, weakness, and some abdominal discomfort in the right upper quadrant. They could also be suffering from jaundice, bleeding, ascites, and edema. They're going to have elevated liver enzymes, and an ultrasound and a contrast CT are used for diagnostics. For liver cancer, there's not a whole lot of treatments out there, and surgical resection and liver transplantation are typically going to be your treatment. TACE is transarterial embolization, and that's going to be an injection of microscopic embolic beads. This is going to cut off the blood supply, and this is followed by a tumor ablation. This is going to be used for non-resectable tumors, or tumors that cannot be removed. There's also SIRT, which is selective internal radiation therapy. And this causes a partial occlusion of the portal artery, which limits the blood flow to the liver, and this is also used for non-resectable tumors. RFA is radiofrequency ablation, and that uses heat to destroy cancer cells. Cryotherapy is just the opposite of that, and it uses liquid nitrogen to freeze the tumors. And then advanced cases will require end-of-life care or hospice or palliative approaches. Liver transplantation, these are going to be for clients with end-stage liver disease or acute liver failure. The donor can be living, like a blood relative or a spouse. They will remove a single lobe of the liver, because keep in mind the liver will regenerate. They could also obtain a liver from an organ donor, like a deceased organ donor. Complications from this can include rejection, infection, and bleeding. And anytime we're talking about transplantation, these patients are going to be on medications for the rest of their life. So education is going to be extremely important with this. And these recipients often feel guilt, anxiety, and fear of rejection, because rejection can be a major concern with them. And this concludes Chapter 53, Concepts of Care for Clients with Liver Problems.